Good morning, everyone, and welcome to our CAD Quality Exchange. We've decided for this quarter we'll do a webinar so that you'll have a little visual while we talk. And we're going to go ahead and get started. I am Kristen Waller. I'm the QSI Director for Arkansas. If at any time during this presentation you have any questions or comments, this is an open discussion. Feel free to ask as we go along. You do not have to wait until the end. Just hit *6 to come off mute, and when you're done, you can hit *6 and go back on mute. Our agenda for today, we want to talk a little bit about Heart Month, dates to remember, Mission Lifeline Systems of Care, the award process for last year's data. We have Tiffany Weaver from St. David's, Austin, Texas, joining us today. We have some resources for you, a few minutes on Get With the Guidelines Afib, and then some more open discussion at the end. This is Heart Month. Today kicks off Heart Month, and you probably received this daily love note yesterday in your email. And these are just light tips, recipes. It's not a whole lot of information in the email, but we will be sending one out daily. If you did not receive this and you would love a love note, you can email swaquality@heart.org, and that stands for Southwest Affiliate quality@heart.org, and we can add you to our list. Tomorrow is National Wear Red Day. I want to encourage you to talk to your administration if y'all have certain uniform colors or guidelines or rules. If you could talk to them and see if maybe they could allow staff to add just a little bit of red tomorrow, and maybe open some discussion with patients about heart attack warning signs and symptoms, why you're wearing red, and Heart Month. Okay, dates to remember. If you enrolled with Get With the Guidelines CAD by February 1st, which is today, then you qualify for a complimentary historical data upload. And that will move any of your action Get With the Guidelines data from 2015, January of 2015, to the present date. So this upload must be completed by March 31st. So some have tried, and it was easy. There was no problems involved. They had their IT department help them, and some it's been a little more complicated. So I encourage you to go ahead and start on that now, and don't wait until March 31st because it must be completed by March 31st. Also on March 31st, all 2017 data must be entered for awards. In the spring, we have a new enhanced CAD data entry platform coming. All of your data that's in there now will transition seamlessly. You won't have to do anything. So we're looking forward to that enhanced platform that's coming in the spring. Sometime in the late spring, awards will be announced. In June, abstracts for scientific sessions are due. In July, we will have the U.S. News and World Report advertisement for our silver and gold hospitals. And then in November, scientific sessions are planned for Chicago. So we want to take just a moment and talk about Get With the Guidelines CAD and Systems of Care. I'm assuming most of you on this call today are probably from receiving hospitals, and you probably have things lined out. You know what you have to do on your end, but you are dependent on referring centers, getting that EKG, and getting them out quickly, or giving thrombolytics if they can't meet the door-in, door-out goal of 120 minutes. And you are also very dependent on your EMS providers doing an EKG in the field and activating from the field. So sometimes we fall out as a receiving center if our referring centers or our EMS providers are not doing things on their end to help us out. So we want to involve everybody in our area, in our region, that takes care of STEMI patients. So I would encourage you to encourage your smaller hospitals to join Get With the Guidelines CAD. as a referring hospital because they can be recognized for getting an EKG within 10 minutes and getting them in and out the door quickly, and the same for EMS. They are recognized for activating from the field, doing EKGs, and things that you need them to do in order for things to run smoothly on your end. So I want to go over the receiving measures, what we're looking for a STEMI receiving center to gain recognition for your 2017 data. Now, I want to remind you that for 2017 only, you have only had to enter 1 quarter of data. And if you were silver or gold last year, then you could keep that silver or gold with 1 quarter. If you did not enter any data last year, then you could be bronze. If you wanted to advance, if you were silver last year and you wanted to be gold this year, then you would need to enter 2 quarters of data, and that data would need to meet the requirements. So what we're looking at is the door-to-balloon time of less than or equal to 90 minutes, and those are for patients that show up directly at your door, or if EMS, their first medical contact to balloon is 90 minutes, so it's very important that they activate from the field. And then there's also an exception there of if the EMS has a drive time of greater than 45 minutes, but you can get the PCI done in less than 30 minutes. So that's going to help out. I know sometimes there's a long drive and it's caused us to fall out in the past, but I want you to take a look at that second box there and see that where that's listed. We're looking at aspirin within 24 hours of arrival, and then for discharge, your aspirin, your beta blocker, an ACE or an ARB, smoking cessation, and then our plus measure, if you're looking to be like a gold plus, then you would need to be meeting the door-to-device time of less than 120 minutes for patients that are doing the door-in, door-out. So our volume requirements is you must have at least 9 STEMI records per quarter. And you want to meet the achievement score of 75% or greater on all STEMI measures and must have a composite score of 85%. So these are for your PCI receiving centers. For the referring centers, we want to make sure we get that door-to-first ECG within 10 minutes or door-to-needle within 30, or if you're transferring out, going for that door-in, door-out, then we want to make sure that you get them in and out your door within 45 minutes. Now, the aspirin at discharge, beta at discharge, all of those discharge things will not apply to you unless you keep the STEMI patient there at your hospital. So for our referring centers, you must have at least 2 STEMI records per quarter. And then, of course, EMS, they can be recognized as well, and their application is open now until April the 2nd. And so these are some of the things that we're looking for at EMS. If you want to encourage them to apply for Mission Lifeline as well, they can go online and do that now until April 2nd. And they're looking for the percentage of patients that have non-traumatic chest pain that are getting that 12-lead EKG in the field, the ones that are being activated from the field. So there are several things there, too. And they have plus measures as well. And then they have some reporting measures that they can do. Non-STEMI measures are the same, whether you are a receiving or a referring hospital. The volume requirements are different, but the measures are the same. And we're looking for patients referred to cardiac rehab, that ACE or ARB, dual antiplatelet therapy for the medically managed non-STEMI patients. So you want to get the aspirin and the antiplatelet therapy. And that is only required at 65% of the time. And then you want to get the LV systolic function evaluated during the admission or planned for after discharge. So if they had one a year ago, a month ago, it's not going to count. They need to have it done this admission or planned for after discharge, and then smoking cessation as well. So if you're a receiving center, you need at least 9 per quarter, and if you're referring, you need at least 2. Okay. When you're in the patient management tool for CAD, I just want to remind you that there are a couple of videos that can help you. If you forget how to do something, you can certainly reach out to your local QSI director. But if you're wanting a little more training, when you're on your community page, the home page, there's the advanced reporting. It's a recorded video that explains how to create reports, run reports. It's probably between 20, 25 minutes. And then there's also one on downloading. So if you're keeping up with a separate Excel spreadsheet, you can actually just create one from the data that you've entered, and you can customize it for what your hospital is looking for. So I'm going to stop sharing for just a moment so that we can go into quintiles. Okay, so this is what the community page looks like and Get with the Guidelines CAD. I'm sure you're familiar with it. I'm going to click over here on the reports icon. Once you're in to the reports, you can click on Configurable Measures Reports. Change your time period. I'm going to do annually for 2017. And then I'm going to look at STEMI receiving measures. I want to keep it as a bar chart. And then I'm going to generate a report. And here I can see that my primary PCI of less than or equal to 90 minutes, I'm only at 81%. Looks like I had 3 patients that fell out. So I might want to drill down on that, look at that, or maybe I'm more concerned with my first medical contact to primary PCI within 90 minutes. We're only at 66% there. So what I'm going to do is I'm going to back on out. Still in the configurable measures reporting. And I want to look at the Mission Lifeline First Medical Contact Primary PCI. And instead of looking at a bar chart, I want to look at patient records. I want to figure out who it is that fell out. I'm also going to see over here just a quick description of this measure. And then I'm going to scroll down here and generate a report. Okay, so it's showing me those that are included in the result, which means that they came by EMS, or some that are excluded, and they are excluded because they were either a walk-in or maybe their EKG in the ambulance did not show STEMI. They didn't actually show a STEMI until the second EKG in the ER. For whatever reason, they're excluded. So I can just click on this little arrow and it will filter it for me. So it's got all the ones that are included at the top, and I want to look at the numerator, and I want to sort it as well. I've got all the ones that didn't meet criteria. They got a no. They're included, but they got a no. And they did not have an exception listed. So we can pull and look at times here. We can see what time their first medical contact was and what time the first PCI was. So we can tell that we are over time, over 90 minutes there. And I want to go directly into that chart, so I just click on the patient number, and it will open it up, and it will show me what's going on. I can kind of look over my times and review it and see if maybe there was an abstraction error, or maybe there was we didn't list a contraindication, an exception. Maybe we were doing CPR when they came in. Had to intubate, had to stop in the ER, something else was going on. So this will just let you see the first medical contact. They departed scene, so it's not looking like that there were any issues there. And we're looking over at the hospitalization tab. Did the cath lab get activated in time? Probably not. So if EMS was on the scene at 11:30 and we didn't activate the cath lab till 12:45, then there's an issue there. So that's how you can use the reports to help you. Let me go out of this and show you how you can compare to other hospitals as well. And this, of course, is just a demo. So I believe when we pull this up to compare to other hospitals, you're not going to see a difference. But I do, for this demo's sake, we're going to compare to other Texas hospitals. We're going to generate a report. Oh, and I see what I did there. Okay, so we have to control, we want to control click on my hospital and then whatever else that you're trying to compare it to. Maybe you're an academic hospital or certain bed size. So you just control to click on, you want to compare your hospital and another hospital, the Texas hospitals. So it's showing side by side. They're all equal because this is a demo for the sake of the demo. But it would have listed my hospitals and where we're at and then all the other Texas hospitals or whatever you're comparing it to. So I just wanted to make sure you were aware of that as well. And I'm going to, there's also your measures listed here. We can go to the home page. And your resources, you can click on this tab right here, and resources will pop up. Coding instructions, you can click on that as well. When you're in the coding instructions for CAD, let's pull those up. So when you first pull them up, you can, if you are looking for something under the discharge tab, you can click on that and it will take you directly to the information for the discharge tab. Or if you're wanting to search for something, you can click on the print coding instructions, right click to find, and then maybe type in beta blocker. And it should pull up anytime beta blocker listed. Let's see. So there it is highlighted right there. So that some people will print the coding instructions to keep them where they can read them, but they do update from time to time, so there's an easy way to look for things in the coding instructions as well. So I'm going to stop sharing for just a second so that we can get back to the PowerPoint. Okay, and now we have Tiffany Weaver from St. David's Healthcare, and she has some slides that she wants to share about Get with the Guidelines CAD and Mission Lifeline. So Tiffany, if you could come off mute, just hit *6.
Good morning. How's everyone doing?
I'm doing great. Thank you, Tiffany.
Okay. So I'll just dive right in if you want to head to the next slide. Next slide, please. So just to give a brief background with Austin, Texas, based on some 2017 data, we've got an estimated population of 931,831 people, so the 11th most populous city in the U.S. So we are fairly fast growing. We're estimated to hit 3.2 million residents here in the next 12 years or so. And then everybody's probably heard of University of Texas, so we are housed here, and that's actually just up the road from one of our sister facilities within the St. David's network. Next slide, please. We do have, as part of St. David's Healthcare, we have about 6 total hospitals and then a children's hospital, several ambulatory surgery centers. The map here shows you specifically where North Austin is in comparison to some of our other facilities. And in conjunction with that, we have a surgical hospital just up the road in Round Rock, the Children's Hospital on campus here at North Austin, a freestanding ER in Pflugerville, and all told, that's 424 beds. So that's just within the 1,500 beds of St. David's Healthcare. Next slide, please. For our regional involvement, we work a lot with our Regional Advisory Council for the capital areas. There's 11 counties, and you can see it on the map there. So we are located within Travis County, but we receive patients from north in Williamson and south in Hayes County, sometimes and from Bastrop to the east. And then we work with the Cardiac Care Work Group. So we provide rapid assessment and transportation to appropriate facility, working with EMS for that, pre-hospital and hospital quality process improvement metrics. We have a database project that we're finishing up. And then we also have some collaborative community outreach in terms of EMS education, as well as working with EMS to educate the community in symptoms of MI and calling 911 for treatment. Next slide, please. So just a little brief breakdown of our patients that we've had within the last year. More often they are male, almost 70%, and then the majority of our patients are Caucasian, but we do get African American and Asian, and then other races is primarily a few Hawaiian and that type of thing, Pacific Islander. Next slide, please. So we looked at some of our metrics, and so we've been looking at how to decrease and ensure that we maintain a door to EKG less than 10 minutes. Maintaining our door to balloon, we've been fortunate enough to have a great cath lab, ER, and in-house staff working to maintain that door to balloon less than 90 minutes and working with EMS on that. The majority of our patients will even get door to balloon, even with EMS involvement, in less than 60 minutes, sometimes less than 45 minutes. And then we did encounter a little hiccup for a couple of quarters with our cardiac rehab referrals. We had some changes to our documentation system, and so we realized we had patients falling through the cracks there, so we needed to increase that rate of referrals again. We have a lot of tools that we use for our practice in excellent care. We do concurrent review, making sure that all MI patients that receive PCI, we do review them concurrently to make sure that they have STEMI patients with that door to balloon, and looking at our discharge meds. We use evidence-based protocols based on clinical practice guidelines. We do rounding on the units, so for our med-surg units and cardiac units, there's golden hour, just spending 5 to 10 minutes with each nurse about their patients, making sure all the needs are met. And then critical care rounding in the ICU, that's multidisciplinary. We do notify nurses through our documentation system with a status board to post our core measures and those discharge needs. And then we educate in our health stream, which is a platform that our parent company, HCA, as well as St. David's Healthcare manages. And then we do provide feedback to EMS. We try to do that within 48 hours of the event If we can get it sorted out, make sure we have the right EMS agency, because we have several in our area, we can get that within a day is our goal. Next slide, please. So looking at our EKGs, we realized we did have some that were overnight. We even expanded it out to include all of our chest pain patients, not just those with a diagnosis of MI. And overnight, we realized sometimes our covering department with respiratory therapy weren't always getting those orders or being able to complete them timely. So we did have instances with the direct admissions where those patients weren't getting an EKG in 10 minutes. So around February of 2017, we started looking at our process, and we did what we call a failure mode effects analysis. So that took a couple of months, and that was literally breaking down every single step of the process between patient arrival and completion of an EKG, and the different ways that they would be ordered if there was a possibility that that was affecting completion. We did identify actions, and the biggest one we found was we were having multiple phone numbers for nurses to call when they needed an EKG completed. So we went to a single extension, and with that we had IT assistance to help set up a rollover. So the nurse only calls one number during the day that actually notifies two different EKG techs. So two different numbers, phones, physical phones, receive the call, receive that notification, and then they work with each other to determine who will be completing that EKG. And then that phone is handed off during the evening hours and weekends to our coverage department with respiratory therapy. And then we're monitoring our compliance with that and how well that direct handoff is going. So we're auditing anything there. And so that was started in October that we went live with the handoff, and in August we went live for the single extension for the nurses to call. So for the last quarter last year, we didn't have any EKGs that were missed. Next slide, please. So looking at our other picture-wise here, a little graph representation. So on the top, we have what we by quarter from Action Registry before we switched over to CAD. And so you can see that we did have those opportunities. For us, yes, we were meeting the metric for things, but we prefer to aim higher. We have a high standard of care, so we weren't meeting the metrics that we wanted. And so we did make some changes with our, like I mentioned, with the EKG process. For our STEMI patients, we do review all outliers, so anybody that did not get a PCI within 90 minutes, and there is no documentation of a clinical reason for delay, like difficulty accessing the lesion or crossing the vessel, anything like that. We do review those for opportunities. And then for our cardiac rehab, we did make some changes to our documentation system, and we were actually able to link within that. So if a nurse answers a specific question in the discharge instructions, she or he will then be prompted to print a list of cardiac rehab facilities available within the St. David's network. So that is printed out and given to the patient. And then those we expanded out, so it's not just cardiac rehab for our MI patients, that's patients who receive any type of PCI, no matter the diagnosis, a CABG or cardiac surgery, and patients with heart failure as well are included in that. So you can see that we were running just around 80 to 90% for 2016 into 2017, and we've been able to bump it up to 83%, 88% so far for 2017, the rest of 2017 there. Next slide, please. So just some tips. We made a clean break since we determined that we only needed 1 quarter of data to maintain our Gold Plus STEMI Receiving Center status with Mission Lifeline. We determined start of quarter 3, every patient discharged on or after July 1st, that was going into the CAD registry. So we will utilize the historic upload just so we have as much data as possible within the CAD registry, but it was just a clean break abstracting into the new registry. And we did take the advice of our QSI director here in Austin to abstract a few cases on paper, and then we double-checked each other. We're fortunate enough to have a cath lab team that is bought into wanting to make sure these metrics are met, and they actually do the abstractions in-house after the patients are discharged, and we have final coding. But we worked together and double-checked each other to make sure everybody was understanding the coding instructions, and we would all answer the questions the same way. And then I'm coordinating with IT to make sure that our historic upload process runs smoothly, and then I access everything appropriately from Action, and it's sent to Quintiles for upload. And then we've been able to use a lot of our resources, so I recommend everybody make sure they know their local AHA representative. Quintile support is great, and then other facilities in your region. Our QSI director here in Austin has put me in touch with the other facilities, even not within the St. David's network. So that's been a huge help, and we love helping everybody else. We all want the same thing for our patients, and that's the best care possible. Next slide, please. So that's what I have. Let me know if you have any questions.
Okay, if we don't have any questions, we'll continue on. There is a free mobile app. It's AHA Guidelines on the Go. You can download that on your iPhone or Android, and it's just a quick access to all of the guidelines. Most recently, I believe it was last week, the stroke guidelines were updated, and they were immediately available on this app. So if you would like to take note of that and get it on your phone or your iPad, that would be helpful for you, a free resource available to you. Also, starting February 11th, I believe, it's Cardiac Rehab Week. So make sure you love on your cardiac rehabs a little bit that week. It's usually always the week that has Valentine's in it. So if you would, share with them resources that are available on the AHA heart.org website. The address is there at the top. It's kind of long, so if you just want to go to www.heart.org and in the search engine type cardiac rehab, it will take you to this site right here. And, you know, some of those hard-to-answer questions are addressed. What is cardiac rehab and how will I benefit from it? We often have patients that don't want to come exercise. They don't see the need. But I will tell you from my cardiac rehab experience, it can be a wonderful thing. Sometimes even with men that are healthy and active, they get a little anxious after a heart attack or once they realize that they have the need for stents. And this will kind of calm their fears. You can educate them on healthy eating, taking care of themselves, how to deal with stress. You know, it's a wonderful thing. For the elderly population, it's getting them out of the house however many times a week that y'all have it. For us, it was 3 times a week. Some, it might be 4 or 5 times a week, however you run your cardiac rehab. But it's an opportunity for the nurse to check their blood pressure, to look for trends, check their medications, making sure that they have everything that they need, that they're not taking 2 of the same thing because it's called by different names and they just don't know. And so it's also a great way to get a call into the doctor for them when they're holding back and not reaching out, or if they're just not really sure how to get into contact with their doctor. So please share this with your cardiac rehab nurses and exercise physiologists. And also, I'm sure you are all well aware, it is the flu season, and a new study came out in the New England Journal, and you can search this. You've probably seen it. But they have found that the week after the flu, there's an increased risk of having a heart attack, a 6 times increase in having a heart attack after the flu. So my background, I did some abstracting, and I was a STEMI coordinator, and I found last season all of these patients that had the flu that were having heart attacks, and I just, you know, found that fascinating. And there is actually a study out that you can read about that. Okay, now, Deb, are you on the line?
I'm here.
Oh, okay. Thanks, Deb. I'm going to go on mute while you talk about Afib.
Okay. So I'm Deb Most, and I am the Senior Director for the Southwest Affiliate and oversee the Get With the Guidelines Stroke and Afib. And we just wanted to make sure that people are aware of the Afib module. We do have a module specific to that. Next slide, please. So I'm not sure if you're aware, but Afib is on the rise. There's a lot of people that have it. There's a lot of people that have it and don't know it. Right now, there are more than 2.7 million people that suffer from Afib, and that is expected to double by 2050. And why is that important? Because it's costing the U.S. $26 billion annually to care for these patients, and each hospitalized Afib patient, regardless of what their diagnosis is, costs an extra $8,750. So that's a pretty good chunk of money that if we can control some of their risk factors and help them get things under control, then we may have a big cost savings for the hospital. And also the readmission within 30 days of discharge is part of the bundling, so that can result in the CMS hospital penalty. Next slide, please. So health related. So the Afib patients, there's not a unit like, we have the coronary unit or we have the stroke unit. There's not really a unit where these patients are housed. They're kind of housed all over the system, all over the hospital. So in order for them, it's very difficult for them to get consistent care with evidence-based guidelines. So right now we have about 191 hospitals that are participating in Afib, which can be benchmarked against about 54,000 records. So there's a fair amount of patients that you can benchmark against, just like the other modules we have. Additionally, there's only 50 to 60% of eligible patients receive anticoagulant therapy. That's a pretty sad deal because the patients are 5 times more likely to have a stroke. So they really need to be anticoagulated. That needs to be monitored. And then they also have gaps in care that result in serious complications, like I said, such as stroke. So the Afib patients are 2 times more likely to be hospitalized than non-Afib patients. Like I said, the 5-time increase in stroke, and there's a 3 times more likely to undergo multiple admissions. So there again, the 30-day penalty, and then the 3 times increased rate or risk of heart failure. So Afib kind of touches on all of the cardiac, all of the vascular issues, and we do have that program to help with that. So we can help to actually affect the patient's care with the newest, next slide please, with the newest updated guidelines. So the PMT for Afib is just like any other ones with stroke, with CAD, where there's real-time data collection, and it's all based on guidelines. There's point-of-care educational materials that you can print to provide for your patients. The integrated decision support, and that's through the Quintiles, Akivia now that it's called, and then to arrange discharge and follow-up care forms. So the patients are able to be followed from admission all the way through discharge and into, a lot of people we're seeing more and more Afib clinics popping up, so some of that information can be recorded for follow-up at the 180 days. In addition, there's availability of one-on-one consultation from your directors, AHA directors, the QSI, and they're more than happy to help you get started on that. By using the tool, just like the other modules, you can reduce readmissions and comorbidities, again, because following the latest guidelines. And so all patients are getting the very best care, and all patients are assessed appropriately. There's also education, the webinars, local workshops, patient education tools. If you go online to the Afib website, there's a lot of educational materials that you can download and give to your patients. And there's also a support group that the patients can join and just get emails, so you can send emails and questions to other patients who have Afib, maybe other patients that are thinking about going into having an ablation, all those kind of things. So the newest feature is now there is an EP tab so that you can follow and all your patients that go through the EP lab as well, along with the follow-up care that goes along with that. So again, it's a robust tool. It has the same public recognition as the other modules. For achievement, 85% compliance, you need 90 days for bronze, a year for silver, and 2 consecutive years for gold. And that's for all of the performance measures. There are quality measures that are listed in there, and there's definitions that go along with it, but those are not a part of the award system at this time. So in concluding, it's just really a cost savings. It saves costs and it saves lives. And it holds the hospitals to the latest scientific guidelines. So, you know, if you're wanting or considering doing maybe CVCOE or anything like that, then you may want to consider the Afib module. And that's all I have. Any questions? Okay, thanks, Kristen.
Thank you, Deb. Okay, so now we'll open it up for any questions or comments. Maybe you want to share fun things that y'all have planned at your hospital for Heart Month, or best practices, or how you involve your referral centers and EMS in your system of care. Anything at all, just come off mute by hitting *6, or you can type a question or comment in the little chat box. Lonnie, can you think of anything that I maybe missed or overlooked that you might want to add?
Hi, good morning, everyone. It's Lonnie Den. No, great information, Kristen and Tiffany and Deb. Fantastic. So I can't think of anything else. Anyone have any abstraction questions or recognition questions that they want to ask? We've got open forum time, and or any best practices you want to share. And you have to press *6 to unmute your line. So when you joined, your line was automatically muted. So if you want to speak, you need to press *6 to come off mute.
Michelle, do we have any questions in the chat box? I can't see the chat box.
No questions.
Okay. Well, I guess if we don't have any questions or comments or anything to share, I guess we can go ahead and end a little early today. If you do have something that you want to reach out to us for, you can contact your local QSI director. If you're not sure who that is, then just email us at swaquality@heart.org, or you can reach me at kristen.waller@heart.org. And thank you so much for your time today. Y'all have a great day.
Thanks, everyone.